Declan. It's still winter in Melbourne.
It is, but we got a visitor from Canada joining us today.
It's not winter.
We've dragged him from a northern
hemisphere. I thought he
hemisphere
might
summer.
say that.
So the German-Canadian GU medical oncologist Christian Kollmannsberger, we'll introduce him properly in a minute, reckons this is not real winter. But probably a good point, is it?
That's a good point. I thought he might say that as the words were coming out of my mouth.
We will introduce Christian.
It's great to have him in the studio.
It is, and it's great to have friend of the podcast Ben Tran back in the studio.
Great to be back.
Yeah, good to see you, Ben.
Yeah, love being here.
An advisor of the podcast. Where's your jacket, Ben?
I forgot it today. I've been seeing patients. So.
Oh, fair enough.
You can wear your GU
You can wear your GU card.
That's true. That's true. I can publicise it to the patients, get them to listen.
Yep.
And your beanie.
Lots of patients listen to GU Cast. Maybe some of Ben Tran's patients are listening today. And if you are, I wish you well. Today we're going to talk about testis cancer. It's always popular when we talk about it, Renu, and everyone always says we don't talk about topics like testis cancer often enough. But here you go, a full-blown 3 hot topics in testis cancer we're going to do today.
Yes, it takes me back to the podcast we did last year with Rob Hamilton. They were the 3 big waves of testis cancer. Do you remember that?
Yeah.
We caught 3 big waves. So today...
Because we were on the Gold Coast.
We were on the Gold Coast, for Hands Up. Do you remember that, Ben?
Yeah.
That was a
Were we
great
skiing down 3 big slopes today, with the Canadian theme?
True.
Yeah.
Yeah. 3 big slopes of testis cancer, Christian.
3 black
no pressure, of course.
3 black runs in testis cancer.
3 black runs. Oh, yeah.
Anyway, there are 3 topics coming up. I'll tell you what they are now, and then we will ask Ben to introduce Christian to us and tell us why he's a good person to talk about testis cancer.
He's the best.
He is the best. So the 3 hot topics, stay tuned if you want to be updated in testis cancer. Or first of all, adjuvant chemo, balancing the early gains, give the chemo up front when we can't see anything, versus the late effects of chemotherapy. So we want an answer from these 2 today on who benefits from adjuvant chemo, how do you pick the best patients, etc., etc.
And we'll do a vote at the end.
Oh, yeah.
Who's for adjuvant chemo?
Great. They're presumably going to be big fans. They're medical oncologists. They have one trick. Yeah, let's give the chemo now.
Give chemo.
Number 2, primary RPLND for you urologists out there as well, of course, one of the great operations in GU oncology. But it's traditionally a big open surgery and quite a big deal even for these younger, fitter men with metastatic disease.
So who should do it?
Yeah.
Who should not do it?
And what about the robot? Does that
What
make
about
a
the
difference?
robot?
Or is that just a disruptor? Are we tempted into doing surgery, or are surgeons tempted in because they have a robot, etc.? So the question is for primary RPLND. So this is for patients who have not yet had chemo, but they've got some nodes in the retroperitoneum. Does robotic surgery change the proposition, the value proposition of surgery? And finally, we talked about this thing on the last podcast as well. So it must have been
microRNA?
Yeah, microRNA or 371. Did I get it right?
That's right.
Yeah,
microRNA 371.
microRNA 371. So stay tuned. I've asked him to give us the bluffer's guide to microRNA 371 because it definitely is a big topic in testis cancer, isn't it? And it did come up when Rob Hamilton discussed it last year. So let's see where we are. But Ben, over to you. Who is this guy, Christian Kollmannsberger?
Gives me great pleasure to have picked up Christian from the hotel in my Jeep Wrangler, the black Jeep Wrangler. Took over some speed humps, made him realise how important a Jeep is in a suburban Melbourne. So took it here today, Declan.
Christian looks thoroughly impressed.
Yes.
But Christian and I go way back. We're old friends, or actually, in fact, we're young friends who've been friends for a long time, something like that. We've known each other for a long time. He is one of the greatest people I've known. He's super nice. He's great perspective, and he also has the same perspective as me, which makes this kind of podcast today going to be even better. There's going to be no arguments, a lot of agreements on how to make you guys behave yourselves.
Maybe we'll have to be
urologists.
the disagreeers.
But Christian is a medical oncologist at BCCA in Vancouver. He leads the medical oncology group and kind of expert in testes and kidney cancer, but we're going to focus on testes cancer today.
Very good.
Okay, great.
Welcome, Christian.
Thank you very much. Thanks for having
Are
me.
you enjoying Melbourne so far?
I do. It's always nice to come to Australia. Great people, lots of old friends, similar systems, similar problems. It's very easy to fit in.
Yeah, it's great. And what are you here for? Are you on an educational tour or doing something?
Yeah.
Pretty good.
good.
Great. And is he coming to Peter Mac later in the week?
Well, we're going to talk about whether you wanted to come to our tumour board tomorrow morning, but we can talk about that later.
Have to know what
You
time.
don't have to
Yeah,
commit
it might be super
I
early.
live on the podcast.
I have a telephone
But you got a
conference
dinner-
at home tomorrow morning.
Oh, yeah.
So
And you
we'll
got
see.
a dinner tomorrow night with us, with some
Yeah.
of the others
Yeah,
as
yeah,
well.
yeah.
Yeah.
Jam-packed.
All
Sounds
right.
good. Has
Renu.
much changed in testis cancer, Christian, in the last decade?
Has much changed? No, nothing has much changed in testis cancer in 30 years. But I do think that we are entering now an era where things are going to change. And I do think that microRNA, which we will talk about a little bit later, has the potential to really impact what we do and how we do things. It's not a drug, obviously, but I do think it can potentially create incredible value in better selecting patients for certain things. And we can talk about that afterwards. And then I think with the introduction of novel therapies like bispecific antibodies, antibody-drug conjugates, other things, we will see that pop over into the testis cancer space. I think the most interesting part that we see right now is Claudin-6 directed therapies. Claudin-6 is a oncofetal protein that usually appears in the embryogenesis and then goes away, but it reappears in when malignant tumors form. And virtually 100% of testis cancer is Claudin-6 positive.
Wow.
High-grade serous ovarian cancer in about 70 to 90%, and then other tumor types to a lesser degree. But there's now a whole wave of studies underway with Claudin-6 directed antibody-drug conjugates, bispecific antibodies, even CAR T-cell therapy. And preliminary data have shown some activities. So I think that is really interesting because as we've seen over the last, I would say 10 years, all the novel strategies in oncology, whether it's targeted therapy or immunotherapy, it just simply doesn't work in testis cancer. We are still treating them with old-fashioned chemotherapy. And although we have been using cisplatin since 1976, we still don't know why there's a small group of patients that is cisplatin refractory. So we are really relying on very old things, which is comfortable because we know what we are doing. And of course, the cure rates are unparalleled in oncology. And it is extremely difficult to introduce new drugs because if you have a cure rate of more than 90%, every change in your regimen actually has a real potential of making things worse. But we will see. I think for the first time in the last, I would say 20 years, there are things on the horizon that can really change things again.
You know what, I think for many years, decades, being a testis cancer doctor has all been about the art of medicine because the data was already there. But now for the first time, it's also about the cutting edge science. So things are happening very quickly and it's kind of bringing that balance together.
Let's go back to the start then, our first topic, Renu.
Oh, this is an age-old question, isn't it?
The adjuvant chemo thing.
The adjuvant chemo.
And of course, you're right, Christian, when you say like these cure rates have been unparalleled, but it's been a traditional paradigm of showing that systemic chemo works. But Ben, as we sit here mid-2025, can you tell us a bit about adjuvant chemo? Can you summarize it in...
for other cancers, when you're diagnosed at an early stage, there's a risk of relapse. And if you relapse, you become incurable. So in other cancers like bowel cancer or even kidney cancer, in modern days, there is a role for adjuvant treatment to prevent relapse and therefore maybe increase cure. But for testicular cancers, Christian's been saying, we've been curing patients for a long time now. I don't think there's any role for adjuvant chemotherapy in stage 1 testicular cancer.
It's going to be a short topic, topic number 1.
Zero role.
Wow.
Yeah.
That is the definitive answer from Ben Tran.
Christian, what do you think?
Well, I have to admit, I kind of agree with you.
Yes.
I think the overriding principle there's a couple of overriding principles when we talk about adjuvant therapy. Overriding principle number 1 is people don't die from stage 1 testis cancer, irrespective of what you do. Number 2, it's not about the cure. We know we cure them. It's curing them with the least impact on their quality of life. Because whatever we do in that early stage, these are 25, 30-year-old people. What happens 25 years down the road matters very much. If you radiate a 75-year-old, what happens 25 years down the road, maybe not so much. Yeah. But in a 25-year, it matters. And I think there should be really no discussion about adjuvant chemotherapy or even worse, adjuvant radiation in stage 1 seminoma. The relapse rate in seminoma is about roughly 20%, 15 to 20%.
Maximum.
15 to 20%. In other words, 80 to 85% of patients are cured with orchiectomy alone. Why would you expose them to chemotherapy or radiation? And you could argue, well, we can give them carboplatin, which it has limited toxicity. if you do it long enough, things happen, and we absolutely have no 25 or 30 years data for adjuvant carboplatin. The same applies to low risk stage 1 non-seminoma, without lymphovascular invasion. 15% risk of recurrence. Why would you treat them? So the group that remains is the high risk group, and that's where the discussion takes place. Now, every other tumor type would probably love to have that discussion because we are basically nitpicking on a very high level. In Europe, you have a higher chance to get adjuvant chemo. In North America and in Australia, you probably don't. And the risk of recurrence for these patients is about 50%. That also means 50% are cured. And I think there's a number of things that, for me personally, come into play when I look at and talk to these patients. So the first thing is that, as I said, 50% of patients don't need chemotherapy. The chemotherapy in that instance is BEP. That is a toxic regimen. And you can seriously harm somebody with one cycle of BEP. And that is just for me personally. If I give a patient chemotherapy, I have to justify that to myself because I will give that patient side effects and toxicity and potentially give them lifelong issues. I can justify that if I know that this is what the patient needs because there is no other option. But if the other option is you just watch him and you may get away with it, or if they relapse, and we can talk about that also when we talk about primary RPLND, in today's world, just because they relapse doesn't mean that they have to have chemotherapy. Not all patients will need chemotherapy. So for me, it is really a question, how do I cure the total population of these patients with the least impact on their quality of life and the least amount of toxicity?
Can I give you an argument that some of my colleagues in Melbourne would give me for a reason to give adjuvant, which I don't believe is a strong argument? They say, well, this patient is probably going to be non-compliant. They're not going to turn up for their surveillance visit, so I should give them chemotherapy now. Yeah. What's your response to that?
That's a complete... I'm not allowed to say things on podcasts, but it's a very weak argument. Yeah. Let's put it this way. Why it's a very weak argument? You cannot judge compliance in the very vast majority of patients. In Vancouver, I've had literally homeless people who showed up for every appointment. I have people that live up north that need to travel 2 days to get to my clinic, and they show up for their appointment. And I can tell you which is the most unreliable group of patients. Guess what? Physicians.
Yeah, for sure.
Because they have never time and they forget about their appointment because they are so busy. Oh, I forgot the blood work. Yeah. I think, and keep in mind, all the studies we have that were done with active surveillance that consistently show the same outcome, close to 100% cure rate, they have the patients who drop out built in. So it's not a good argument.
My argument back is compliance is as much a physician problem as it is a patient problem.
Yeah. And the other thing you need to tell your patients, you only need to have them compliant for 2 to 4 years. In testis in stage 1 non-seminoma, if they are lymphovascular invasion positive, the median time to relapse is 4 to 5 months.
Okay.
If they are lymphovascular invasion negative, it's about 15, 16 months. For stage 1 seminoma, it's about the same. And 98% of recurrences in stage 1 non-seminoma happen in the first 2 years. In seminoma, it's about 3 years.
Yep.
So that's really the critical period. And if you can keep them on, then that's good. And I think compliance is usually never a problem if the young man is in a relationship.
That's true.
Because all you have to tell them is, I call your mom or your wife and she's going to give you hell if you don't show up. And that is true. I think if we did a study, that would be the most positive predictive factor for compliance. And the remaining boys, it's usually not a problem. I mean, the cure rates speak for themselves.
There you go, Renu.
But surely you do have those patients, Christian, especially those that belong in the high-risk non-seminoma group. You know, if you tell them you have a 1 in 2 chance of recurring, do you have those patients who want everything? And how do you deal with that?
So I think there's a difference in mentality and region. I'm serious. I mean, as you know, I trained in Germany. And in Germany, there were a lot more patients who said, well, I don't want to run around with a 50% risk of recurrence. I just want to have something that makes it lower. On the West Coast, where people are usually pretty relaxed, people will not take chemotherapy until you tell them this is absolutely what you need. Otherwise, there's no chance for you to do anything. So I don't have that problem very much.
It's how you present it to the patient as well, right? So
No,
some of our colleagues who are pro-adjuvant chemotherapy, patients will come away with it, right? Because I don't think there's really a role for it. Patients will rarely push for it.
So we can say, as of now, mid-2025, I love clear, easy messages. They haven't even
adjuvant
confused
chemo.
it by saying, oh, well, now, of course, if we have this, or 371, blah, 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 blah. But basically, key message, there's no role for adjuvant chemo, really, give or take. So that's good.
Why give chemo when you don't need it?
Exactly.
Absolutely.
Do you want some chemo? I don't want any chemo.
No, especially if you're going to be reassured, provided you get watched carefully and you're compliant, and we've identified your risk of relapses. It might be 30% for you or 50%, but if you get onto that straight away, we have surgery or we have chemo, and the value proposition changes, of course, when there's a few nodes you can see. So I think that's good. It's really good.
Yeah, the other thing I would like to say is just for people who are still surprisingly unconvinced and give adjuvant chemo, if you do that, then it's one cycle of BEP and not two.
Only one. Okay.
Yes.
Yeah.
When I grew up and trained, it was always two because that's where the study were done.
Yeah.
But in today's world, we actually have better and more data for one cycle, and that clearly shows that it does the same reduction in risk. So if you want to give that, which I don't think is a good thing, but if you give adjuvant therapy, then for non-seminoma, then it should be one cycle of BEP and not two.
And just a brief thing about the toxicity. So I know bleo, lung, etc., peripheral neuropathy. What's the thing that you get most concerned about, Christian? I know you have a long interest in long-term survivorship in these patients. What's the thing you most worry about for toxicity?
So first of all, I don't think there is a safe threshold in terms of long-term toxicity. If you expose enough patients and you measure it, you will have it. And if you look at the excellent data that are coming out of the Scandinavian countries and the Netherlands, because they are really leading the charge in terms of long-term follow-up, Norway, the Svenotika group and the Dutch group, there is a measurable number of patients that have issues. Now, you could argue from a global view, it's not that bad. And that's probably right, but they're still there. Why do you have to expose them if you don't need them? The second thing is, one cycle of BEP, you have the acute toxicity. You lose your hair, you can have nausea, vomiting, but even more so, even with one cycle of BEP, the patient can get away with permanent kidney damage. You have a risk of infection, sepsis, and if you do it long enough, at some point the patient will die. We all see these cases. We all have heard about these cases. We all have discussed these cases. I even was involved in a case, not in my institution, in an international institution, where a patient passed away from one cycle of adjuvant carboplatin for seminoma because he got septic and didn't immediately go to the doctor, and bad things happened. That is something that would keep me up for years at night, because you basically exposed a patient to a treatment that had an 80% chance that he didn't even need it. So for me, that's just not something I would like to expose a patient. And of course, the argument will always be, well, but it doesn't happen very often. Yeah, you say that until something happens. And keep in mind, when you look at the old New England Journal paper that looked at kidney function, every drop in GFR is associated with a higher mortality long-term. Mm-hmm. So I don't think we should take these things lightly. These are young patients that have their whole productive life in front of them, and we should try to give them the best life possible.
I love it. Renu, topic number 2.
I think we can put that issue to bed.
Yeah,
yep.
I'm encouraged by these guys. So what about the next one then? Primary RPLND. So a brief kind of back to the explainer on it is, this is where practices vary between Europe, Australia, and certainly the US for patients who have evidence of retroperitoneal disease. Following testis cancer treatment, or even at the time. Certainly here in Australia and in the UK where I trained, chemotherapy was the first line management there. Whereas in the US, there's always been a bit of a trend towards RPLND surgery as first-line option. And so here in Australia, and I think in many other countries, is what's been changing that a little bit is robotic surgery. So this is kind of a contentious topic, is, if we can do an RPLND maybe with less of the traditional morbidity of a big operation.
Nerve sparing.
Nerve sparing templates, function sparing. Does surgery compete, shall we say, a little bit more with chemotherapy for patients with metastatic disease in the retroperitoneum? Yeah, that's the discussion. Or is it all just like robot nonsense?
Can I give some background? So this is like, let's split it into stage 2 seminoma and stage 2 non-seminoma. So these are lymph gland recurrences in the retroperitoneum only. You'd hope they'd be less than 3 centimeters in size. This is a group where typically the standard of care is involved chemotherapy. But now we're starting to explore, and actually it's considered a standard of care now. Now we're starting to think about surgical resection of these nodes in a template. And it depends on the quality of the surgery, but hopefully by doing this, we can cure patients that needed chemotherapy, but cure them without chemotherapy.
Without all that toxicity that you guys talked about.
And without all that long-term effect.
Yeah. And Christian, you pointed out that one thing also that deters you from giving adjuvant treatment is now you've got this other very real option if and when they recur.
Yeah. So the same reasons why I don't want to give adjuvant chemotherapy in stage 1, if I have an alternative in stage 2, then I'm more than happy to closely look at that. Chemotherapy is not good for you and radiation is not good for you either. Both can have significant long-term toxicity, and even so it is probably a relatively modest group of patients. Why do that if you don't have to? And I think, based on my experience with the surgeons I've worked with in my life, an RPLND, and apparently particularly a primary RPLND, in the hands of an experienced surgeon, that is a surgery that has very little long-term morbidity and mortality. For sure, much less than with chemotherapy. And when we go back to the principle, the overriding principle, it's not just about cure. It's about cure with the least
preserved quality
toxicity
of life.
And the most preserved quality of life. Then RPLND becomes a very interesting option. Now, there's a couple of qualifiers that Ben is itching to throw in here, because it is about patient selection, surgeon experience, and the right patient for the right option.
Yeah.
Can we talk about patient selection?
Yes.
What are your, so before we do that, what are you quoting to patients now as a recurrence risk post RPLND? Do you kind of say, I kind of say 30%? It depends.
It depends. So first of all, it depends on whether you talk about seminoma, non-seminoma, and then you depends on what the extent of the lymph node metastasis is. If you take a stage 2A marker negative stage, a stage 2A non-seminoma, a primary RPLND done by an experienced surgeon probably has at most a 10% relapse risk. If you have an early stage 2, you probably have more kind of a 20, maybe 25% relapse risk.
And how does that compare with chemotherapy? So if you're trying to compare primary RPLND versus chemotherapy,
if you give a patient
in terms of
3 cycles of chemotherapy for a stage 2 tumor, your risk of recurrence is probably at most 5%.
Okay.
With all the side effects of chemotherapy.
If we compare the stages that are options for both, because if you have a 4 or 5 centimeter lymph node in the retroperitoneum, I'm not sure whether I would recommend a primary RPLND anymore.
And I don't think I don't like comparing surgery to chemo in this setting. Comparing recurrence risks, it's like surgery is almost like I'm trying to cure without chemotherapy. I've got chemotherapy in my back pocket, but it's how can I cure without chemotherapy? What a percentage of patients can I cure without chemo
and avoid that toxicity of chemo?
And that's always an argument against primary RPLND by people who say, well, the recurrence risk is much higher. And I kind of, but the purpose is to not needing chemo. So you minimize further the group of patients that needs chemotherapy.
Yeah.
So it's patient selection. One of the things that I've realized, and it was a problem during COVID here in Melbourne, was surgical list delays. So my patient had a scan. I thought, you're a great candidate. You're a 2.5 centimeter lymph node, maybe a seminoma, right? Let's say stage 2A/B seminoma, great candidate. wait list for surgery. But by the time the surgery happens, it's 3 months down the track. The staging scan is old. They've kind of been lost in some kind of list, and they go ahead with the surgery. And by the time the surgery happens, maybe it's now a 4 centimetre node. And so one of the things I've been very cognizant about since then is making sure this patient has a scan within a month of surgery, just to make sure that they are suitable.
Definitely.
And I think from a surgical perspective, that's very important for surgical planning as well. And I mean, these are big, major operations. I mean, we're talking about RPLND as a whole, not even primary RPLND. This is any RPLND is big, major surgery with a high risk of complications. And, you know, we have a small cohort of surgeons who do this in Melbourne. And, you know, from what I hear, a primary RPLND and RPLND post-chemo are like chalk and cheese. You know, a primary RPLND is a dream compared to...
So my urologists call it tell me. They start to literally drooling over it when I sent them one.
Yeah.
Yeah, that's true.
It's apparently a beautiful operation, I quote.
It's like an anatomy textbook, right?
Yes.
And for those surgeons who are experienced at doing post-chemo RPLNDs, absolutely, this is right up their alley.
But I don't think a urologist who hasn't done many should be dabbling in this, right?
No, I think most people would agree with you, Ben. This is not something to dabble in.
So that brings us back to the second point. You know, we practice very similar between Vancouver and Melbourne. And we are lucky that we have a system where that operation is done by a dedicated group of urologists. And it's not an operation that is done everywhere, because there is actually randomized evidence for that. In 1998, the German group conducted or published a study that looked at primary RPLND versus one cycle of BEP for stage 1 non-seminoma. And they could show that the complication rate and, most importantly, the in-field recurrence rate went up drastically in centers that did not do a minimum required number of RPLNDs per year. So I think that is a disclaimer that needs to be put on it, because I think Ben and myself as medical oncologists, we're big fans of primary RPLND for the correct patient done by the correct surgeon.
So patient selection and surgeon selection
that's kind of the disclaimer that is on there. And I think the recognition, and this is data that has mostly come out over the last 10 years, that both chemotherapy and radiation have measurable long-term risks, has led to this reintroduction of primary RPLND in stage 2 seminoma. RPLND in stage 2 seminoma has never been really systematically explored, because seminoma is so radiation sensitive, and everybody thought, well, we can just radiate that. And now 30 or 40 years later, we realize, well, radiation is not good for you. And we lose patients to radiation-induced complications. So that led to this kind of revival of primary RPLND. Correct me if I'm wrong, I just quote my surgeons, a primary RPLND in a seminoma is not more difficult than a primary RPLND in a non-seminoma. It's the post-chemotherapy seminomas that are much, much more difficult than post-chemotherapy non-seminomas.
You're right.
But again, I think while we use it as an option, it needs to be done by the correct surgeon. And I think in stage 2 seminoma, there is one other thing that I think we still need to work on, and that is what the correct template is. We participated in the SEM study, one of the 3 or 4 studies that were published over the last few years. And I was surprised, because the SEM study required 1 or 2 lymph nodes up to 3 centimeters. When I saw the path report of the patients we included, the microscopic extent of the seminoma was much higher than what we saw on CT scan or what we saw on PET scan, because the study had a PET sub-study. And it did not always follow anatomical templates. I had a recent discussion at ASCO GU, with Axel Heidenreich, who did the co-trim study, similar study.
We had him recently on a podcast about that.
And he's working on the same thing. He's mapped it out, and he says, yes, he is doing a slight modification to his template because he saw in his own patient population that there was a certain region that quite frequently harbored microscopic disease. So I think that's something we need to iron out a little bit.
Yeah.
But I do think that for the correct patient with the correct surgeon, primary RPLND in stage 2 seminoma is a very good option. Maybe even better than in non-seminoma because we know they are biologically slower. So the number of patients who may have occult metastasis outside of the retroperitoneum is probably much lower.
I have a potential area of disagreement that I'm predicting we may disagree on. Maybe we'll bring it up.
Okay.
A lot of
Careful.
primary RPLND, well, it's not a lot, 5 to 10%, you end up having it's nothing in the specimen.
Yes.
And so that means sometimes we're giving chemotherapy unnecessarily as well, right? But
We don't give chemotherapy after a primary RPLND.
No. I mean, like
If you were going to have chemotherapy.
instead of primary RPLND, I'm just saying,
yes.
So there are a percentage of patients we're giving treatment unnecessarily because we don't know that we think it's a recurrence, but it's not.
Absolutely.
So we are very PET heavy at Peter Mac. So for a seminoma, I will do an FDG PET for a 2 centimeter lesion before I commit them to a primary RPLND. What are your thoughts on that?
I basically never pull the trigger immediately on a stage 2A seminoma.
Definitely for chemotherapy, but do you think if surgery remains an option, if you leave it too late?
Not even there. I usually do a short follow-up CT scan to see whether it continues to grow.
That makes sense, doesn't it?
We love PET scans, though.
We do.
Yeah.
We do.
And the value in that situation based on more recent data is probably not that bad, although you will still have false positives.
Yeah.
I had some I had 2 on a SEM study, which had granulomatous inflammation. And I even had a case where a patient had a lymphoma in the retroperitoneum, not on the study, outside of the study. So I think that's a very valid question. But again, in order to avoid that, irrespective of what treatment you give, I always do a repeat scan and see whether it continues to grow, and then discuss what
Have you looked at the correlation of PET uptake and pathology, Ben? Is there a good concordance?
There is if you look the right way.
Yeah.
But you're
Turn
right.
up the signal a bit.
Right, but PET is unclear medicine, right? So it's an extra bit of information that we use, and if it looks like it doesn't fit, then you don't believe it, I guess. So Torgram's data from the Swenateka data, PET did reduce that rate of path T0, right? So it's something we've incorporated.
So just before we leave the RPLND topic, so the advent of robotic RPLND, Ben, in Melbourne now, a lot of our RPLND surgeons have gone towards a robotic route. For the majority of cases, there are still the cases that require the open approach for post-chemo especially. But for primary RPLND, I think these surgeons who are experienced RPLND surgeons and experienced robotic surgeons would want to take that on. Do you think that's increased your referral pattern?
It certainly has, because
the
immediate morbidity for the patient is much less than an open RPLND. They're leaving hospital the next day. They have a minimal scar burden. It's back to normal life very quickly.
Yeah. So there we have it. Primary RPLND.
Very good. So
it's all about patient selection,
so far
surgeon selection.
These 2 eminent medical oncologists have hardly pushed chemotherapy at all in this podcast.
They sound like surgeons.
All of a sudden, they are friends again.
Can I be an honorary urologist?
We're going to refer all our metastatic hormone-sensitive prostate cancer patients to you two.
No
chemo. Speak for yourself. Okay, that's great. Final topic, and we hinted at the start, this microRNA R371, or how do you call it? Like 371, I heard you call it before.
371.
371.
MicroRNA 371.
So I asked you to, Ben, to put together a bluffer's guide for people like me who, like to pretend we know about these things. But 371 has been big news, hasn't it? ANZUP, I know you've been involved in a number of trials.
So it's one of the biggest development in testis cancer, as Christian's indicated for a long time. Yeah. It looks like the most promising biomarker for testicular cancer there has ever been. So it has the promise to detect testicular cancer before a scan can detect it, before existing tumour markers can detect a recurrence. And it might guide us. This is the key, right? It might guide us whether patients should have adjuvant chemotherapy, where we've spoken how we're totally against it.
Yeah, but
so maybe 371 can identify the patient where that is the ideal place to sit. And there's several studies now studying the clinical utility of 371. There's the SWOG 1823, right, which is
Has completed accrual.
and there's the Climate Australian version of that, which is one patient away from completing accrual. And there's the pediatric-led AGCT 1531, which is also completed accrual, and they're about to read out later this year, is what I've been told. So we're going to...
what's that patient population?
These are all stage 1.
Stage 1
Yeah,
non-seminomas.
they're all stage 1. But
And seminoma. Okay. To identify because it's to detect the presence of active disease, isn't that the idea after primary treatment?
yeah, so there's actually quite a few areas where a valid biomarkers could help us a lot. And as Ben pointed out correctly, microRNA 371 has all the characteristics of a perfect biomarker. And a lot of the questions we discussed so far the discussion could change completely if microRNA 371 turns out the way we want it to turn out. If you look at stage 1, it can be used, ideally it would be used in a post-orchiectomy patient. You see whether microRNA 371 persists or not. If it persists and the patient has a recurrence, that would be an indication for adjuvant therapy, because then there's a 90% risk of recurrence or something like that. And then adjuvant therapy would look very good. Yeah. It could potentially be used to reduce the number of scans patients need because it detects it comes up in the blood much earlier. It also works in seminoma, where we don't have conventional tumor markers. The only situation where it does not work is teratoma. So in the stage 1 and stage 2 algorithm of testis cancer, it has a lot of important implications. I can describe a case we had. That was the lymphoma case I referred before to. I had a patient, 40 years old, with a left-sided testis cancer, and 6 months later, he had a 3-centimeter lymph node right in the landing zone. We did even a PET scan, lit up like a Christmas tree, and the patient was part of one of our microRNA research protocols, and he was microRNA negative.
Negative, nothing.
And I said to Lucia, you need to measure that again, because what looks like a duck, what walks like a duck. Yeah. She measured it again, and Lucia Nappi is the oncologist who runs the microRNA program in our institution, at the lab part. And she said, no, it's negative. So we biopsied it. It was a large cell lymphoma. Wow. And we would have cured the large cell lymphoma, with BEP. 5 years later, he would have had a recurrence with a lymphoma, and everybody would have said, well, now he's a lymphoma. So it could also potentially identify the patient Ben referred to previously that actually do not have active tumor in their lymph nodes that are enlarged. And keep in mind, Rob Hamilton's series even showed that in the series of patients that relapse from stage 1, 10% were still not, they were still pathologic N0. So in all of these clinical situations, microRNA could help us a lot. And if we refine it, even in the post-chemotherapy setting, in my opinion, there's a couple of things to be said about that. There is still no standardized method how to use that. It starts with, do you use plasma, do you use serum? And I do think that that particularly in the very early stages, where you really look at very microscopic amounts of microRNA because the patient is stage 1 post-orchiectomy, our current detection methods may not be sensitive enough. We have to work on that. That's part of what Dr. Nappi does in her lab as well. Look at other ways to more sensitive ways to find microRNA 371, so that hopefully one day it can fulfill that function of telling us which patient is destined to relapse, which patient is not.
Is it an all or nothing thing? Are they either
it's
negative
an all or
or
nothing
positive?
thing.
Okay.
There are exactly 2 conditions where microRNA 371 is positive. That is a germ cell tumor or pregnancy. Number 2 in men is rather unlikely. So if it's positive, it's a germ cell tumor. And the amount of microRNA correlates with the amount of tumor, and if the tumor is eradicated, so for example, post-orchiectomy for a stage 1 patient, microRNA disappears within 48 hours. Oh. So it has all the hallmarks of a perfect biomarker.
And it's cheap.
And it's cheap.
That's my next question. So, and
a few $100.
A couple $100.
And so, and if this were ever to be used...
If you use a PCR.
Yeah.
But we want to refine that because it may not be sensitive enough for very early traces of microRNA 371.
And if this were ever to be used in a screening setting, how would you interpret these results?
Well, I'm not sure if there's a role in screening. Like the testicle's very external. It's very easy to examine. Like you guys will
your
feel
fingers
that.
are your screening guide.
Yeah. This is for after.
I think it's really post-orchidectomy, stage 2 disease, looking for RPLND or treat with chemo. You want to confirm that. That's a role for it. We're looking for other roles. You know, if it turns out to be as good as we think it is, there's going to be so many roles for it.
But keep in mind, 80% of seminoma patients are stage 1 and 60% of non-seminoma patients are stage 1. So the majority of testicular cancer patients these days are stage 1 patients. And there it could have potentially have a huge impact on how we do things.
How we follow these patients. And so at the moment, it's only in clinical trials. Is that the case? It's not been recommended in guidelines.
So
are any of you using
it is not recommended in clinical guidelines. We do not use it outside of research protocols. In Europe, there's already some people who have formed companies and sell it as a test, which I think is premature. That's my personal opinion. Ben can disagree with that. I think we need to better standardize the method and then, of course, work on refining the method over time.
Because it's not a patented thing itself. You're just looking for a fragment.
You cannot patent that.
So it's just different assays can be patented.
That's right.
So that's
correct.
why it's cheap. Well, that's good, Renu, isn't it? Mm. I love it. What a cheery one to be ending.
Yeah,
with.
Definitely.
Did you enjoy that?
I did.
1, 2, 3.
Learned a lot.
Pick their brains.
Yeah.
Yeah.
They seem to agree on most things, Declan.
It's really good. Well, then we're going to wrap it up. Ben and Christian, that was absolutely awesome. It was really fun having the pair of you in the studio. It's always great when we have studio guests. We get much more banter like this.
Combined, such amazing experience in treating testis cancer. It's really quite impressive.
The audience love it when we talk about things that we don't talk about often enough, like testis cancer. So hopefully an
they
update
love it when we learn, Declan.
When we learn. It's not difficult.
So should I talk about prostate cancer? Oh.
In your lane, sir. But yeah, and I know a lot of trainees listen to this podcast and they'll often share it around among their WhatsApp groups saying, there's been a really good one on hot topics and testis cancer, and bang, everyone will be onto it. So we're really grateful to you for sharing your thoughts on it. And
thank you.
Hopefully there'll be people popping up at their tumour boards next week saying, what about a R317 on this one, Dr. Chief Medical Oncologist in their hospital, like I'll be doing next week, trying to pretend I know about this. So that's it, Renu.
Let's go get some dinner.
Great podcast.
Thank you very much.
They're going to take you out for dinner, Christian, I believe. That's good.
It'll be good.
Treat them well. And we'll be back soon with another episode of GUcast. Thanks very much to everyone for listening, for watching. Please do subscribe if you don't already. Rate, review us, all that sort of stuff, so we can grow our audience even more. Thank you very much.
Thank you.